Jim Patton. I'm the Theme 8 chair this year for EMBC 2012. And it's my incredible pleasure to introduce someone I've been following for my entire career, Dr. Savio Wu. Dr. Savio Wu comes to us from a round path back to his own hometown of San Diego, where he began his career. He actually started his career with a bachelor's in mechanical engineering from Chico State in Northern California, and then did some work in Seattle. He's got his master's and his PhD. His master's was in mechanical engineering, and his PhD was one of the first programs to actually have a bioengineering degree. So we're very proud to see this happen. This was in 1971. He's been a member of the Departments of Surgery and Bioengineering at the University of California at San Diego from 1970 to 1990, where he moved and went to Pittsburgh and joined the University of Pittsburgh and has held numerous faculty positions there, including a distinguished professorship. And he's been there since 1990. He's a very prominent researcher, but also held posts in the Institute of Medicine, the National Academy of Medicine, and then the Academia Sinica in China, and also in the IOC, Olympic Academy of Sports Science, where he was a founding member. He's also received earlier today the IEEE Gold Medal for innovations in healthcare. And he's also received the Olympic Gold Medal from the IOC for his prize in sports science. Numerous offices and editorial boards. He's published over 300 papers and has also authored and co-authored book chapters, over 140 of those, one of which I keep on my desk and use daily. And also 12 other books as well. So very prolific, and we're very proud to have him. Please help me in thanking him and welcoming him to give his talk today. Dr. Savio Wu.
Thank you very much. Good afternoon. I know it is a little bit late in the day, and I'm really appreciative that you will still bear with me for the next 45 minutes or so. I am very proud to always tell you what bioengineering has done, and I view we are really the bridge between biology and clinical medicine. And today I will try to share this story with you, that what I feel about the bridge between biology and orthopedic sports medicine, because that's an area that I have most of my career devoted to. My slides are not moving. I guess I use this one. Slight technical. I was going to tell you a joke, but I can't. Yeah, they are not moving. Try again. I think that I had to go back to the old way. Okay, that's good. That's good. Okay, all right. Oh, it works. Well, I'm very proud of my dear friend Zipei being the president of EMBS, and He is the one that introduced me to come to this meeting and give this talk. And space beautiful Dr. Annie. We were in Boston earlier this year, and of course with Donna and a lot of very good people from the IEEE and EMBS. And of course I thank Michael Koo, the picture my wife took this morning, for program chair and get me to this beautiful spot to give a talk. My topic is I would like to tell you a little bit of history, then I will tell you how we have our, this bioengineering work change from the bench, contribute to the bedside. And to conclude, I would talk a little bit about opportunities and challenges that are upon us. The history of bioengineering is really started more than 650 years ago, 600 or so. Of course, Da Vinci, he gave us all the muscles and bones in the human body and how things really work in terms of mechanics. And Galileo, of course, he used mechanics to describe force, motion, and also he studied strength of materials as well. And then came Alfonso Borelli. He wrote the Animal Motion, the book Animal Motion, and it's really a fascinating book. And American Society of Biomechanics have actually gave the highest honor in his name. And then we got Robert Hooke that gave us the Hooke's Law, and actually Hooke already did some work on cellular, describing a cell in the micrographic sense. And you have to think about this is like at the early 17th century, this is already being done. Isaac Newton, of course, gave us the mathematics that we can use them for biomechanics, bioengineering. And more classical work related to musculoskeletal engineering, probably you can give some credit to Edward Muybridge. And he's the one that used cinematography to study motion of human and also animal movement. I think this is the one that he won a bet from Mr. Stanford about horse actually leave the ground when they run. And Muybridge actually is very well known in the International Society of Biomechanics community because they gave the highest honor as Muybridge Medal. Art Steinler, Vern Ehrman from UC Berkeley, they really did a lot of classical work in the musculoskeletal area. And finally, Carl Hirsch, in the early time, maybe 50, 60 years ago, he's actually an orthopedic surgeon, but he believed in the mechanics and he wanted to introduce into the field of orthopedics. And I think he really brought the idea of having surgeon and engineer work together and bring it to fruition. Of course, the bioengineering, I call the bioengineering revolution, is really in the 70s. Unfortunately for me, I just started my academic career at that time, and it was just like sometimes, even though Dr. Brody said, you make your own luck, but there is some luck involved that I happened to be at that time. And then a lot of study on ligaments and tendon, bone, articular cartilage, joint mechanics, spine biomechanics, and even impact or injury due to automobile. And functional assessment and development of new mathematical and computational methods, as well as design of implant. They all happened in that decade of the 70s. And you can see bioengineering has contributed a lot, and there are a lot of achievement in orthopedics, namely total joint replacements. This is big time now, and this morning a couple of the awardees, they have their hips replaced and knees replaced. Some even have shoulder replacement. Of course, fracture fixation is another one. We now know how to take care of fracture much better than before, and with much less infection. Spinal fixation is more recent, and I think this is, as everyone's getting a little bit older, have spinal back pain, these become important as well. Then, in terms of sports medicine, we have arthroscopy development, reconstruction ligaments, lots of fixation devices, because most of the work in ligament tendons are involved in the attachment of these soft tissues to bone. So the most common injury in sports medicine, and it's becoming even more important today because first of all, we sit all day playing with a computer, then we have to go exercise. And that's where we injure ourselves. And of course, on the other spectrum, the high-priced athletes, when the team is signing contract with an athlete for $100 million, their injury become real problem for in a financial point of view. So knee ligament injuries are very common, especially the ACL. Everybody had heard about ACL injury. And MCL injury is also common too. Posterior cruciate, less common, but no less problem. In terms of tendon, you heard of patellar tendon injuries, jumper's knee, rotator cuff of the shoulder, and Achilles tendon of the heel. And of course, Achilles tendon is what make the Chinese hurdler. He won in Athens, but then he had Achilles tendon problem for both Olympics in Beijing and recently in London. So just a short video show you that these things happen. This young lady probably done these thousands of times, but this particular time she somehow plant her foot in the wrong place and you get this injury. So I thought this is a very, well, maybe we shouldn't see it just a little bit too much. But this kind of injury occur in the ACL injury. You can think of probably about 100,000 per year in the United States alone. Worldwide, probably 250,000. MCL is a little bit less, but there's also another 50,000 so combined ACL MCL injury. Most the football players will experience this kind of traumatic injury. And so basically, this thing, we have 206 bones are all connected by ligaments and tendons. So they can all be injured in one way or another. Therefore, it's a huge problem. If you're a healthy individual, you like to do things, you have injury to ligament tendon, even just a minor injury, it really put a damper on your activity. So it's a huge economic and social issue. So I would like to tell you a little bit of a history. How do we go from bench to bedside? The first thing you need to do to understand ligaments, you got to study the normal first. If you don't know the normal, you can't do anything about it. Then I will tell you a little bit more about how the ligament maintain their homeostasis, how do they heal, and how do they contribute to joint motion. And I'll talk a little bit more about anterior cruciate ligament reconstruction, and finally maybe the new aspect of what we call functional tissue engineering. Now, you take a ligament like the rabbit MCL, it's connecting the femur to the tibia on the medial side, the inside of your knee. And you can see it's a pretty nice structure, nice and long. So it's very suitable for us to study it. Under microscope, there's a lot of parallel fiber structure in the spur with very spindle-shaped cells. And they are naturally arranged in the kind of a crimp or undulating patterns. And if nothing else, I think they make pretty good art in your office. Now, we can measure them. So as an engineer, the first thing we like to do is let's just test them, stretch them to failure. But being that they are pretty short, you have to be very careful so you don't bend. You have to design special devices so you can test them. And you can get these kind of stress-strain curve. Is basically nonlinear concave upward. At the lower lows, their stiffness is very low, the modulus is low. As the low increase, the modulus increase accordingly. And that's a very interesting, this special function for it, because if you, at the normal activity, such as you're walking or I'm waving my arm around talking, you don't want the ligament tendons to be too stiff. You want them to guide the joint to move, but move very easily. But if I step on something or I try to not carefully go down the step and not see the step, then the load gets on the joint gets high, and you want the ligaments to be stiff to prevent it from the joint from moving out of whack or damage the cartilage and things like that. So it's well designed specifically for their function. And also, when we measure a whole bunch of ligaments, such as medial collateral ligament of the knee, inferior glenohumeral ligament of the shoulder, the interosseous ligament of the forearm, you can see they have different properties. And that's also by design, because your knee is relatively pretty good, going, like a pendulum swing back and forth. Shoulder, you get the largest motion, so you don't want the ligament to be very tight. You want them to be pretty loose. And interosseous ligament, you don't want the radius and ulna to display, so they have the highest stiffness. So you can see that they are very, very designed specifically for specific joints. And also, by and large, ligaments are for resist tensile loading. Therefore, they're anisotropic. So if you load the ligament along the longitudinal direction, they're much, much stiffer than if you load them in the transverse direction, recognizing these anisotropy. And ligament is also viscoelastic because, sometimes all soft tissues behave this way. When you first load it, it's stiff, and you cyclic load it, it gets softer and softer. It undergoes these stress relaxation phenomena, and we have developed theories, engineers developed theories to describe these viscoelastic phenomena. This particular one is called the quasi-linear viscoelastic theory, originally developed by Professor Fong at UCSD, and we adapted it to the ligaments and tendons. But they're basically for small deformation, small strain. And we also developed what we call single integral finite strain theory. It's a little bit more complicated, but it's more real for ligament tendon function. As you know, this paper was published in 1996, and I have not been able to get another student to continue this study. Nowadays, everybody wants to do a little bit less complicated mathematics, if you will. So that's also the trend. I'm still looking for a student to do that. We also look at the ligaments under homeostasis. Now, it's very interesting. If we normally activity, I classify it in the yellow zone. If you plot the tissue mass, tissue stiffness, and so on, versus the activity level, in the case that you have to immobilize due to injury, in the old days we cast people a lot. It turns out that the property and tissue mass, everything drops very quickly. It goes to the red zone. And if you exercise a lot, you will have, in a green zone, you will gain something, but the gain is small. So it's not a linear phenomena, but it's highly nonlinear. Gains from exercise is moderate, because in our normal activity, we actually load the ligaments, tendon quite a bit. But the penalty for lack of use of immobilization is enormous. So we did a lot of study to characterize them. We understand that we don't want to immobilize tissues. So what are the clinical significance of these kind of a basic normal studies? Well, we now have a much better appreciation that these tissues are indeed alive. Because, back in the 60s, the surgeons saying the ligament is useless, you just cut it and, go on, do your reconstruction or get the bone healed, whatever. We understand also these tissues are alive and can undergo homeostasis. Therefore, the concept of control motion is good, was developed. And because of this type of work, we no longer do much casting. We do functional management now. And also, different property of tissue. Tendons are different from ligaments. Shoulder ligaments, not the same as knee ligaments. And even within the same knee, the anterior cruciate ligament, ACL, is not the same as the medial collateral ligament, MCL. And actually, all the tissue properties are very complex, anisotropic, viscoelastic, and they function, they're designed for function, for the complex function of the joint. Now let me give you an example. Now we know enough about the normal tissue, then we can go to look at how these tissue heal after they injure. And we use a rabbits and goats MCL. We can tear the MCL like this, rupture, just like clinically you see in patients. And this type of rupture, you have to remember, it not only damages the ligament, but it also damages the attachment of the ligament to bone. Therefore, it's not just looking at the ligament alone. You have to look at the ligament-bone complex as a unit. Now, very interestingly, with such a huge rupture, in 10 days, the ligaments united. Very quickly, 10 days, you united. But that doesn't mean the ligament is healed. Okay, it just united. But at the meantime, you look at the insertion site, which on the right panel, you can see that ligament attachment to bone at 10 days is very much disrupted. Okay, so sometimes when you see, oh, the ligament is united, it doesn't mean it's functional. Okay, it's very important to recognize the fact. So the healing, inflammatory healing, unification is a matter of days. But the reparative case, it takes weeks. And if you meet any orthopedic surgeon, for some reason, they always think things in 6 weeks, 9 weeks, 12 weeks, or something like that. But it's really not quite like that. So remodeling, on the other hand, to get it to get back to a little bit like a normal situation, it will take months and sometimes years. Okay, so let's look at this MCL, the rapid heal. At 6 weeks, you see the red line, the low elongation curve. Okay, they have recovered some stiffness, but the ultimate low is not there. At 12 weeks, the yellow line is almost functionally, it functions pretty well, but the ultimate low is about 2/3. And this go on for all the way up to 1 year. What it tells you is that the ligament substance may have recovered, but the attachment is continually very weak because it's so complex, it's very difficult for the body to repair. But still, these kind of data tell us that you can get the MCL to heal without any kind of a surgical management. And so, as a result, the clinical study has been done, and they support these findings. Prior to this, they always operated on an MCL tear. And today, in 2012, nobody operates on the MCL tear. So there's a huge paradigm shift in the management. We functionally manage MCL tear with bracing and so on. So no surgery, functional treatment. So as you can see, it's a very simple example that the engineering work had changed the clinical practice and it's benefit the patient a great deal. Now, when you injure the ACL, on the other hand, the missubstance ACL just cannot heal very well. Unlike the extra-articular ligament, the MCL, it heals well. So they have very different properties, different characteristics. So in general, we do surgical replacement with tissue grafts, okay, be it autograft, patellar tendon, or hamstring tendon, more popular recently, or sometimes using allografts from another person. And the reconstructions are very successful in terms of restoring knee stability and can let people go back to sports activities. And most of the time, we're talking about 9 months to a year for even the first-rate athletes to regain their capability to go back to sports like playing football. But most of people like us use a 1-year effort to do that. So if you go to clinical conference and you hear the orthopedic surgeon present their work, most of them will say, I have 95% or higher successful. And some will say, my results are perfect. Okay. But if you look at the outcome studies, the little fish inside saying that my results are not so perfect. Okay. In the long term, about 20 to 25% of patients have unsatisfactory results that led even to early signs of osteoarthritis. Now, this is what is interesting. About over 3,000 papers probably published on ACL, various aspects in the last 10 years. About 3,000, a little more. 55% of the papers on surgical techniques, okay, 55%. So that works out to about 1,700 papers. So there's all kinds of technique out there to do ACL reconstruction. Only 5% is on outcome. And then, of course, 40% is on complications. So these kind of result data, if you look at these papers, you'll find that the ACL reconstruction problem is really not solved. And there's still a lot to go. It's a huge challenge in sports, orthopedic sports medicine. So what we've done in the early 1990s is to develop a robotic and universal force moment sensor testing system. And this is a system that can be operated under force control or displacement control or hybrid control combined together. The idea of using this robot is robots very faithful in reproduce three-dimensional motion in space. Now, if you have a knee joint, you have some injury, you take out some ligaments, you can really not put the Humpty Dumpty back together, except the robot can say, okay, that's how it was before it was injured. Now, what we did was we used this system. We said, okay, let's take the knee, take a cadaver knee. We want to move the knee in extension and flexion cycle with no external load, just like physicians do these flexion extension passively. But in the meantime, the robot has remembered all the positions when you go through this flexion extension cycle. And I can reproduce that by taking out all the muscles, all the material, all the ligaments, and ask the femur to move with respect to the tibia this way. This is like repeating exactly the joint, as though the joint was intact, like the left video. And if you don't believe me, I really have no thing in contact, but I can do it. So that's a beautiful thing about robot. So the positions are all remembered now. The relative position between the femur and tibia are remembered, irregardless of whether the knee is intact or with nothing in contact. Then we can start to move the robot when you subject the knee to external load from the same starting position from point A to the resulting position, point B. Not only we can do that, but we can also repeat the path of going from point A to point B. And I think that is the most important part, because if we can do that, we can use principle of linear superposition. And you can say before and after in technique, take out the ACL, and you can measure the same motion and measure the difference in force, and that would be the force of the ACL. So we can not only get the knee kinematics and also the in situ forces of ligaments, tendons, cartilage, meniscus, you have it, we can do it. All can be done on the same specimen because we can reproduce the positions and the path of motion. And statistically, it's really good because now we can compare data from the same specimen, and there will be no specimen variation, which is the largest variation. And the statistical power is increased because now it's a repeated measure ANOVA. And it's really a very powerful apparatus, and it's probably more than 20 laboratories now have adopted this system in the world. So we study a whole bunch of variables for ACL reconstruction, use a lot of cadaveric needs in this period of time, wrote a lot of papers so a lot of students can graduate, fellows, and can get famous. We look at various variables such as what kind of graph we choose, where do we put the graph, how do we orient the graph, what kind of graph tension will be the best, what kind of fixation procedure will give the best outcome, and what kind of tunnel motion of the graft in the bone tunnel, and finally the graft healing as well. All this is to help improve the outcome of ACL surgery. Now, as we were doing all this engineering work, the 1980s, what I call the biology revolution. That's where genetic engineering started. Gene therapy is big time, Human Genome Project, and molecular biology comes, and of course tissue engineering, and now stem cells and proteomics and so on. So this is since 1980s. But I do want to share a little bit of history about tissue engineering. Now most of you probably would not know this. The term tissue engineering was coined by Professor Fong, UCSD. And we were together at the NSF Advisory Committee in 1987 in spring in Washington. And we were discussing about how we're going to, how we manipulate tissue function engineering. So Dr. Fong came up with this term. And of course, the next year we immediately, with Dr. Skalak, had a meeting in Lake Tahoe, have biology and engineers sit together in the same room for the first time. And we talk about structure and function. And I always want to remind you the word function. And we only look at tissue engineering as a biological substitute and not dealing with the implants using metallic inorganic material. And the following year, I myself and Professor Seguchi of Japan organized the ASME Tissue Engineering Symposium also to address function. But of course, things have changed in this time. Now there's not a month go by without a major tissue engineering and more recently regeneration meeting that's going on. And this is good. I think this is a wonderful thing that's happening in our field. But if you think back about a dozen years ago, year 2000, biological approach has gained so much weight that bioengineering approach became almost irrelevant. Everybody thinks that we can just inject something and everything will be solved. Even the very famous people said this, that you don't really need anything, all you need is a needle. And the field of tissue engineering was the companies all like they're going to double their growth and every year. But actually only 2 years later, 2012, majority of them went out of business. So right about that time, those of us who started the tissue engineering concept, maybe more engineering, thinking that we must emphasize bioengineering and biomechanics. And right at 2000, there was a book published later on functional tissue engineering. Therefore, the word functional tissue engineering was added. Now, I want to use functional tissue engineering to give you a couple examples. I said the MCL can heal, we change the clinical paradigm. But if you look at the tissue itself, it never improved with time. 6 weeks is same as 12 weeks, same as 52 weeks. So the quality of tissue never improved. You say, well, then how come it works? Well, body just make more of the less quality tissue to do it. Body has no way to remake the original good tissue like the blue line. Okay, it can't do it. So we thought, well, maybe we can, okay, that's a slide showing the poor quality, but the cross-sectional area is increased. You can see from this MRI, the MCL is now much, much thicker and bigger than before. The cross-sectional area is huge now. So there are issues remaining. How do we manage? How can we manipulate so we can get a little bit better tissue quality with time? And we want to use functional tissue engineering this way. Now, to functional tissue engineering to us is three things. You can use growth factor cytokines as one, in which we did that in the early 1994, about 10 years of that. Those days, growth factors were very, very expensive, but we tried. And it was not very difficult. And then, of course, cellular therapy is something we also tried for a number of years, and that's also too difficult. And I'm just a simple bioengineer. I want to do something simple. And so eventually it came to scaffolding. Well, that's something I can understand. Bioscaffold, it is an engineering thing, and a little bit biology, I can handle that. And we've been using that. And particularly, I'm going to tell you about extracellular matrix bioscaffolds. And because that encompasses the scaffold and also the growth factors. Now, the one I'm particularly will tell you today is called the porcine small intestine submucosa. Now, this submucosa is only about 200 micrometers thick, but it's really a non-homogeneous material. When the side is facing the lumen, it actually has compactin structure. It's a barrier, because then the bacteria in the intestine cannot go into our body. But on the other side, the abluminal side is full of growth factor, good stuff, because they need to regenerate themselves and the surrounding tissue, because the intestine is a pretty tough place to survive. And we actually use it to our advantage of these non-homogeneous thin sheet of tissue. And we put two sheets, one cut the patellar tendon, take out the middle third, put a sheet underneath, a sheet above. And you can see that at about 12 weeks later, we have neo-tissue formation that fill the gap, and with 68% increase in volume. And then, of course, the whole patellar tendon have double the stiffness and strength. So the message is that we can get the tendons to grow faster with just simply two sheets. It's not a structural replacement. It's strictly using its biology. And the second study we did was we create a gap of the MCL. We put a layer on it over the top with the abdominal side facing the gap. And sure enough, after 12 to 26 weeks, we get 22% increase in fibril diameter. Now, we have done a lot of healing work at MCL. We can never get larger fibrils. It's always small fibril because the type 5 collagen is always elevated. Type 5 collagen actually sits between type 1 collagen, prevent it from aggregating larger fibril, therefore increase the quality of the tissue. And with one thin layer of SIS, we're able to get larger fibrils and by reducing the type 5-1 ratio. And of course, in terms of the modulus of the tissue, it also increase. So we can, remember I just showed you the curve that with the 6, 12, 52 week, no change in stress strain curve. Now we have change in stress strain curve. So we can manipulate. I wouldn't say regeneration. I would say we can fool the mother nature a little bit and to get some gain, make some gain. So with the success of patellar tendon and MCL, these are extra articular tissue Then we get a little more brave. Let's try ACL. Can we heal the ACL using functional tissue engineering or ECM bioscaffold in particular? And we did actually cut the ACL of the goat, and we repaired and using suture repair as a control group. For the experimental group, we delivered gel, the SIS one layer with gel foam because it's too flimsy to do with gel foam to wrap around the repair site. And then we also make some hydrogel out of SIS. We inject them into it because they can deliver factors a little bit faster. So sure enough, at 12 weeks, the left panel is the sham ACL, and the right, you can see we got a pretty good looking ACL with ECM treatment and hydrogel. Can restore the continuity, and it's also because by the fact that we wrap it around, we prevent it from hypertrophy. The joint space is small. If you have a very large ACL, it wouldn't work very well, interfere with other tissues. So we say, okay, you heal, but you cannot heal big. You can just heal with nice cross-sectional area. And of course, at 12 weeks, we got alignment, we got cells in the right place. Of course, the collagen is not as thin as it could be. It takes 26 weeks to get there. But the exciting thing is we just have a synovium. The synovium is important because it covers the ligament and prevents the synovial fluid from attacking the newly healed tissue. And so give it a chance to go on to remodel. And in terms of mechanical testing, it's about a half of the normal ACL, but it's 2.2 times better than suture repair alone. And it's about 2.5 times in terms of ultimate low. And what we got is pretty close to ACL reconstruction, comparatively. Exciting that we can just use very simple functional tissue engineering approach to heal a ligament that normally does not like to heal. So with the combination of scaffold and hydrogel, they work in synergy. They accelerate the healing, limit excessive growth. They have to give us better structural properties, better collagen alignment, and a synovium. And with that, I think we can go on with some more study on tissue remodeling, get a functional ACL. So ongoing in the laboratory, we are doing longer term studies, of course. We want to look at the mechanism a little bit, how does the SIS hydrogel, SIS increase cellular activity. We have done some cultural experiments. And we also look at SIS is from pig, is a xenograft. So now we have actually a genetic knockout, alpha-gal knockout pig that's available now for people developed for transplant. Because alpha-gal glycositis is actually the biggest problem called immunorejection, and we're looking into that. Other areas of improvement is whether we can add additional initial stiffness, maybe mechanical augmentation to improve the using the ACL earlier, and fiber alignment of the scaffold, and then way to sustain release growth factors, because healing is slow. It's not a quick thing like the MCL. And one of the brand new approaches we're looking at is actually looking at biodegradable metallic scaffolds. And this is mainly made out of magnesium alloy, and then we have actually designed a ring to go over the healing site, wrap, so that we can actually load the ACL right away. And if you can immediately load the ACL, you probably would damage the insertion site less for lack of use. And also, it can be combined with the ECM scaffold and hydrogels used together. And to sustain relief growth factors, these are things that we are looking at today. So in terms of bench to bedside, we're hopeful that we have studied rabbits. We now are successful in goats. We really want to go to human down the line, and that's really our goal on trying to get a new ACL. So I hope I gave you a little flavor about what do we do that actually have clinical relevance. So we have been doing this type of translational work maybe for the last 40 years in this field, and it helped a lot of people. But there are really a lot of opportunity challenges in front of us in this, using this engineering approach to solve clinical problems. And you can think about in every level, from molecules all the way to the body, 10 to the 8th range, they all need engineering. So it's really, really exciting to think about that. Now, not too distant futures or almost in the immediate future, you can see that there will be intelligent diagnostics. We're talking about putting a chip in the body, so your daily function, activity, disease can be monitored at the hospital or doctor's office. So if you happen to go out and drink too much, the doctor will call you tomorrow morning to, hey, you got to turn up that medicine a little bit. Also, distant surgery is another thing. Everybody wants the best surgeon to operate on you. Maybe this is also a possibility very soon. Power imaging, IEEE, probably the biggest contributor to this. You can think about going to a doctor's office. You have your walk through the door, you already have an MRI of your whole body. And then you maybe a 6 foot or 7 foot hologram, and the doctor can look at the hologram with you together, diagnostic ailment, take out your knee and take a look, say this is what I want to do with your injury, and design specific treatment that are patient specific. But really, I'm thinking that if you plot the years, we have our ability to diagnose disease is really going up rapidly. But on the other hand, the effective treatment is going up at a much, much slower rate. So in some respect, you said that's pretty disappointing with all the things that we are doing. 6,000 members of EMBS, we can't catch up with we do so much diagnosis, but not much effective treatment. Well, I look at this as an opportunity. That's a huge opportunity for us. Just think about what we can do to narrow this gap. So, bioengineering will play a key role. Now, I hate to say this because Dr. Bodhi just tell you the experts don't know what they're talking about. And I'm not saying I know what I'm talking about. I'm just saying that I think. Okay, I hope you believe me, but then I think the past success is no guarantee for the success of the future, like the financial advisor always tells us. I think imaging is important because you can measure temporal changes. That's really important. And tissue regeneration is another area that I personally think probably is improved healing better than regeneration. But that's a term that's being used now. Meniscus, cartilage, organ regeneration. A lot of people dream about that. And then, of course, personalized medicine is coming. And then we must think about prevention. I think that is really the key for future. I'm going to give you one example. Now, at the body level, we measure in vivo kinematics. The system, back in the 1990s, our standard marker system using on your body and video analysis. But then you move to point cluster technique for Dr. Andriaki, improve the accuracy a little bit. And bone pins, people put pin in the bone and measure them. And then really now it's going to fluoroscopy. Single plane fluoroscopy, biplane, and so on. All this is to increase the accuracy, okay? So basically now we're talking about we can measure sub-millimeter accuracy at a high frame rate today of the movement of bones during in vivo activity. And I think that's very exciting to us because for ligaments, tendons, you really need this kind of accuracy in order to predict what they're doing. And 3D kinematic data used, and this is where I work with my friends at the Vail, Colorado, using biplane fluoroscopy system. And we measure bone motion in three-dimensional space. Like, for example, you jump or step jump off, or you jump and run. The left panel is the biplane fluoroscopy. You can see that the fluoroscopy scopes are there. The right panel is the motion analysis system. Okay, so it turns out we can compare in the same motion what are the differences. It turns out that motion capture system tend to overestimate the knee rotation. This particular patient has kind of a valgus knee. And now people say, oh, you got a valgus knee, you're going to tear your ACL. Now it turns out that this is not true. Just because the motion capture system tells you that there's more valgus motion. But when you put it on the biplane, we don't see any increase. So basically, what you see may not be what you get. So improved technology and analysis will give you different answers. We find out using this system that our natural musculature is the knee is pretty good in maintaining the kinematics between femur and tibia in all sorts of activities. Well, then why do people tear the ACL? Well, it's almost leading us to think differently. First of all, it must involve the hip, and we start thinking about the hip and the knee work together to injure. And secondly, we think the muscle weakness or imbalance is really the cause. So this is the new thing that we have found now. And the other aspect is that we develop, of course, computational models. We can measure, develop the geometry property, and create a finite element model that we can look at, analyze what the function of the ACL, and even get stress strain data that can be used for cellular studies. And this is advantageous because model will allow you to do more complex loading conditions if it's validated. So I think this is the combined approach that we're going. We need to measure in vivo kinematics, repeat them on the robot, and determine what the ACL is doing. On the other hand, we make models and using same loading condition kinematics, determine what the ACL is doing. We check, we validate. If they're not, we change things, validate, and then we can use this model for a lot of things. Database, we can look at progress, ACL healing, evaluating rehabilitation, injury prevention, all that, all to improve patient outcome. And of course, we can't get it all in one shot. We'll go loop around, and eventually get better. But the challenges are many because the process is not so simple. Of course, you can always read the magazine, this person can cure everything. You can cure arthritis and prostate cancer together for $21.99. That's something really put us out of business. But I think this way, there are a few raw materials, and we make them into a great product like a Lamborghini. It's probably 100 years of history for us to get to this point, okay? 100 years. Now, if we know it takes so much materials engineering, manufacturing, design, test, everything to get to where we are. But if you have knowledge of one molecule, molecular biology, to clinical application, I think it's much more complicated process. I would say many more fold in terms of level of difficulty. So to think that we can just know a molecule and get the solution is probably pretty naive. So I think it doesn't matter how you accelerate it, some things just can't move too fast. Okay, we got to be realistic here. So of course, I go back to Confucius over 2,500 years ago. Say this: to know what you know, to know what you don't know, then you're a person with knowledge. That's almost the same as what Dr. Brody said this morning. So the Confucius, if he were to be alive today, he would probably tell you these words of advice. Beware of inaccuracies on methodology and equipment used. You know, there are so many papers published, probably 20,000 papers published each day. I wonder how many have the accuracy in terms of methods, equipment, data, and statistical analysis. Okay, I think we have to be smart enough to fish them out. Don't believe everything you read, especially you get everything feed to you for free on the internet. A good sports medicine research really requires some thinking, some reading first, some thinking, questioning, discussing before actually doing. Okay, we don't just jump in, just do it. Okay, it's not worth just do it. And not just Googling either. You know, you're saying everything is solutions in a Google. I don't own Google stocks, therefore I am not very interested in Google. You really need to recognize that biology and biomechanics are very, very complex. And you have to respect them. Respect is complexity. Don't just say that, oh, I did the biology and just let the mechanics take care by itself. It doesn't work that way. It really takes a system. You know, you think about it like a solar system. It's so orderly for millions and millions of years. Okay? Of course, I picked the Earth as bioengineering. It's the most beautiful planet in the whole solar system of orthopedic sports medicine. But biology is big. Rehabilitation is also big. Immunology is a big thing too. Yeah, imaging, clinical research, unfortunately, is very small, and statistics and so on. So all these plus more are involved in this system. So the question if you're looking at this system, you may ask me is, well, Dr. Wu, what happened to Pluto? Well, I look at Pluto as quackery, because there's always quackery in whatever you do. And science is no different. Bioengineering is no different. So we want to take that quackery out of our solar system. Okay, we don't include quackery. Watch out for them. So with that, I want to conclude my talk. And there's a whole bunch of students that worked with me in the last 40-somewhat years, and fellows and colleagues. And they really are the one of my team that get to where we are. So with that, I want to thank you very much.
Time for a few questions. I want to remind anybody who has a question to please come to the microphone so it can be heard by everybody. Thanks.
I think probably it's Miller time. So, well, anyway, thank you so much, and I hope to see you at the reception.